So I want to introduce Dr. Best. He practices in Indiana, and he's been known as the king of soft tissue procedure in our private MIS elite community. And he's been performing MIS for past 4.5 years, helping many people in our group. And so I'm like, why not I bring Dr. Best here and have him talk about your take on soft tissue. Dr. Best, please take it away.
Thank you, TJ, and welcome everybody. Thanks for being here. It's powerful procedures MIS. I'm going to talk about soft tissue hammer toe procedures, basic procedures. The types of hammer toes you can do are flexible, semi-rigid, and rigid. And you can do all three as a standalone procedure with soft tissue procedures if done correctly. Soft tissue procedures can be very tedious. They do take time, but they pay off in droves in more ways than another if you're done correctly. The armamentarium of a MIS surgeon is not large. The instruments are relatively simple. I use a number 62 blade personally on a beaver handle for all soft tissue procedures. As far as hammer toe, you can do it severe hammer toes. You can do soft tissue and correct a hammer toe like this, even if it's rigid. The technique of doing it is, for this hammer toe as an example, you take a number 62 blade and you make a small vertical incision over the joint. That's important. You don't want to go too proximally. And you go down and you turn the blade 90 degrees, and you make like a stabbing motion through the extensor tendon down to the capsule. And you can feel the resistance with this blade. It's a very safe blade, it only cuts on the very end. And you make this motion and you release the dorsal capsule. If it's an angulated joint, you do one side or the other. And occasionally, if it's a rigid joint, I go all the way around. Once the dorsum is done, you move to the plantar surface of the toe. And there's multiple areas on the toe where you can make a small incision. Number 62 blade makes a very small incision. I don't suture them. I usually put my incision somewhere near the base of the toe, and that allows me to slip my 62 blade into the joint for capsulotomy, the PIPJ, and another incision for the DIPJ. And it's the same motion. You just it's a small stabbing motion. You can feel the give of the capsule as you release it. You can feel the give of the tendon as you release it. As I'm doing this, the other hand is working. I'm putting the toe in extension, and that pops the tendon up, so they're really easy to feel. It does take time because it's easy to miss a fiber or two of the tendon. I go through it once, I come back, and I always check my work once or twice, and you'll find sometimes you have a fiber or two, and it's not the reason you're getting the results that you would like to get. Then I slip the blade in the plantar aspect of the capsule, and I do the entire plantar aspect. And that sometimes requires a C-arm to get your blade in that joint if it's a rigid hammer toe. For flexible ones, I just do the plantar capsule. For semi-rigid and rigid, I do the entire capsule. Occasionally, that requires another small incision dorsally or a medial or laterally to finish it on top. But generally, you can do it all from the bottom. You slip the blade into the joint, you can go all the way through it and get to the top of the capsule, and you can feel the same resistance up there and release it. You're not done with a hammer toe soft tissue correction until you can dislocate it to PIPJ. Then you know you're done. Same applies to the DIPJ. You release it the same way. And I've found soft tissue procedures for hammer toes and other procedures, hallux malleus, they're great for diabetics with ulcers on the tips of their toe, or we have all had the hard to heal one on the hallux. I use it commonly as a standalone procedure. You always use it as part of your entire procedure if the segment is too long. And there's a few other reasons to do bone work as well. I know my colleagues always do bone work. I don't always do that. But as part of the complete hammer toe picture, where you're doing bone and soft tissue, you want to take your time in a soft tissue and do it first. You'll find you can get great correction with that. And then the bone procedure enhances it to shorten the segment. And sometimes that's combined with metatarsal osteotomy if that's also long. The results are excellent. People love soft tissue procedures. They heal quick. They're right back on their feet again quickly the next day and going about their business. The most important part is equally as important as the technique of the surgery is splinting. In some cases, you need to splint these for 8 to 12 weeks to get optimum results. And it's something you have to emphasize with the patient, show them how to do it. And some are proficient. Sometimes you have to take that task over by using a splint or a combination of splinting and taping, such as the Darko splint. I encourage you all to try to pick this up. This has changed my life, MIS. Thank you, TJ. Once I met TJ and it took off. I was cruising at a large multi-specialty group, and with reimbursement the way it was, you just lose your enthusiasm. My enthusiasm is back. I'm happily working and doing a lot of cases. I encourage you all. There's a big meeting in July of TJ's. I've been to every one except for one. And it's an incredible learning experience. One of the best learning experiences I've ever had in going to any kind of conference. And I've been to many. Top instructors, best in the world, top lecturers. The camaraderie and collegiality is excellent. You'll see all of us there. If you want to learn about soft tissue procedures, if you come, you can grab me. I'll be happy to show you how to do it. And please do it. It'll change your life like it did mine.
Well, thank you so much, Dr. Best. Isn't his last name the best one, Dr. Best? So, again, it's an honor to have you here. And let's move to next MIS procedure I told you guys, which is exostectomy. Again, if you're still in the borderline, I don't feel comfortable making bone cuts and osteotomies. Well, here comes Dr. Timothy Shea. He practiced in Concord, California. And again, he's well-known, respected podiatric surgeon in California. Yet he decided to adapt and start incorporating MIS about 4.5 years ago. Now, Dr. Shea performs, I don't know, like you perform 5 to 8 MIS cases every week?
Yeah, 5 days a week.
It's amazing. So here comes Dr. Timothy Shea. Please welcome him, and he's going to talk about the exostectomy part. Please go ahead.
TJ, and thank you for being here tonight to be able to speak with my friends Larry Best and Helene, who I know are experts in this area as well. And for those of you that are tuning in, a quick background on me. I am not a youngster in practice. I've been in practice for over 50 years. And commonly when people say, well, what the hell made you decide to do this? Why don't you just take it easy and go to like Pebble Beach or play golf or go surfing down in San Diego or something like that? And what happened was, like Dr. Best said, I also was getting frustrated by the discouraging reimbursement by insurance companies and how they had control over patients' lives. And also the fact of always having to schedule things either at the hospital or the surgery center, and I was not in control. And there's a lot of people that were coming in asking about certain things that could be done. And so one of the procedures I wanted to talk about tonight was what we refer to as lump and bump surgery. And lump and bump surgery not technically, but tends to affect more of the older population. These are people not with major deformities of their feet, They're a little older. They want to wear certain shoes. They have been already getting palliative care, or they've been trying palliative care on their own. And there's these lumps and bumps that are still hurting and causing them pain and discomfort. And they want to know, is there any way that something can be done for it other than going to the hospital and going to the surgery center and having a lot of big surgery done? And it was this appeal of doing minimal incision surgery, minimal incision surgery, that appealed to me to offer the patient. The other thing about ostectomy procedures is they fall in between the classic soft tissue procedure and the classic osseous hammer toe procedure. They fill that gap in between where your patient may benefit from something but maybe doesn't need as much on either side. And so in this particular case, you can combine it with soft tissue and you can combine it with other procedures, but can be a standalone type procedure. I just want to go over real quickly the equipment. As you can see, the equipment's not very much. There are varying degrees of what we call side cutting osteotomes. Some people refer to them as burrs. On the left-hand side, you can see a very tiny one called a mini Isham or mini Shannon. In the middle is the classic Shannon, and on the end is the Isham burr. And these all are more than adequate for any type of exostectomy you want to perform. They tend to fall into a couple of different categories. The forefoot category, which is the digital type, and then the midfoot category, and then the rear foot category. I'm just going to show you one example of a forefoot case and one of a midfoot case. Rear foot cases, that's something that you want to discuss with more hands-on kind of a approach if you're already doing it. For a digital approach, so these are very common. I know for sure every one of you after tonight will go back to your office and see at least one of these or two of these cases walk into your office, and at least one or two will ask you, is there anything you can do for this other than trimming the corn or trimming the callus or putting a pad? Because everyone's tried that and it just keeps coming back. So this is kind of your classic so-called kissing corns, lesion on the lateral side of the fourth toe at the PIPJ and lesion on the medial side of the fifth DIPJ or the distal phalanx itself. Sometimes these will be associated with underwriting toes, which are contracted slightly, and that part you would address with the soft tissue release. But there's still always a little bump right there that keeps causing a lesion to recur. And sometimes they may just be straight toes with bumps on them from previous trauma, shoe gear, osteoarthritis, all that kind of stuff that might create exostoses that cause pain and discomfort. In the past, to even fix a small procedure, you would have to make an incision to get to the lesion, to use whatever equipment you wanted to use to get rid of the lesion. And actually, the incision would be more painful than the lesion itself. And so being able to get to it sometimes wouldn't be risk-reward kind of an issue, wouldn't play out. But in this particular kind of case, here we go, next one, there we go. In this case here, what we're able to do is able to access the distal portion of the toe through, and I'm a big fan of Dr. Best's number 62 blade. We're all becoming converts to his thinking in this respect, but it creates a 1 to 2 millimeter portal. We don't even call them incisions. They're portals to allow us to get our equipment into the area with very little tissue dissection. And then once you're down to the area, then you can use your side cutting osteotomes, rotating side cutting osteotomes, and you can burr down on the lateral side of the toe or the medial side of the toe. And in some cases, as noted above, some people like to use suture, some people like to steri-strips, some people don't put anything on it. It's kind of like getting a Band-Aid for going to the doctor's office. I think if you put a suture in, people can prove they had surgery. But the thing is that the portal is so small and the tissue dissection is so small that you get the benefit of the reduction of the exostosis. And by the way, there's enough room to extrude the material out through this portal and then keep it closed over, that these patients require very little bandaging and can, in some cases, ambulate from the office, minimal post-op shoes, sometimes even a sandal or even a regular shoe, depending on how big their shoe is. And so from a distal aspect, you can see post-operatively here, we have reduction on the medial side of the IPJ and on the DIPJ and on the lateral side of the fourth toe as well. And these are very common. everywhere from the hallux interphalangeal joint. Pick every digit, top, bottom, medial, plantar. You're going to find the body forms these bumps for different reasons, and that's it. And that's what bothers the patient. And what you can do with these techniques is you can provide service and relieve their pain there in the office at that time when you want to do it, because you're in control of the procedure, and the patient appreciates this. And as already been mentioned, and I'll reinforce it, these are self-promoting patients. They will go back and tell many people how they're able to get this done and still be able to stay ambulatory and have very little pain or discomfort. Now, in some cases, these will occur a little bit more on the midfoot. And this is sort of our classic midfoot bump on the top of the foot, first metcuneiform joint, sometimes talonavicular joint. But the first metcuneiform one is the one that bothers patients most commonly because they can't tie their shoes. And when they tie their shoes, they get a pinching of the deep perineal nerve or the artery, and they start getting numbness and tingling or pain in their toes. And again, to make an incision across the top of the foot, just to get down to the joint, to use large instruments. In the old days, it was osteotome and mallet, etc. Nowadays, we can approach these from medial. Here you can see we didn't even use a suture. We approached it from medial using a 62 blade. We were able to go down using a side cutting Isham burr and able to smooth down the exostosis. And you can see here how nicely that has been reduced, and very, very little, if no, edema in the foot. There's some other procedures done as well, but this was the one that was giving them a lot of trouble. And so in this case here, it shows that the minimal incision approach, and I tend to focus on the incision approach rather than invasive approach, because you have less dissection, less tissue destruction, patients are more ambulatory, and you have less swelling. And as Dr. Best mentioned, and I was in a similar category, although I wasn't in a multi-group, I was getting at a point where I was getting frustrated with what was going on, and I wanted to get some control of my practice. And it was by being invited to and going to the Open International Convention, where I was able to get exposed to this. And from that, it reinvigorated me back to my starting days out of residency. And now I use it quite a lot in my practice, as TJ mentions, about 5 to 8 cases a week. And these are office-based surgical procedures. And even initially, when I was doing them in the surgery centers, they were amazed that you could do so much work through such a tiny incision. So for those that are familiar with MIS from the old days, forget about it, because we didn't have the equipment, we did not have fluoroscopy, we did not have the techniques, and we did not have the training. So if you were familiar from back in those days, because I was with you, forget that. If you're new to it, please embellish it, because you have 40 to 50 years ahead of you to appreciate this and really enjoy it and have it be a tremendous part of your practice to offer your patients on a regular basis. And I can't say enough about it. So that's kind of my 10 cents on doing for ostectomies. And I don't really see any other type of procedure that would approach the ostectomy as well as a minimal incision surgery. Always got to do one more thing. There we go.
All right. That was a really nice, concise, quick few case studies Dr. Shea shared with us. Again, we do have a private community. We meet every Thursday night. Something like this type of setup. We have 20 to 30 doctors show up every Thursday. We share cases. Dr. Shea, again, he's not just someone who talks. He actually does perform 5 to 8 MIS cases every week. And then, he shares a lot of cases, bone cases, soft tissue cases. But again, thank you for sharing, the exostectomy or ostectomy cases with us.